Hello everyone, my name is Ziad A from St. Francis Hospital and Heart Center, the Cardiovascular Research Foundation, and Columbia University Medical Center. And today I'm going to be talking to you about the management of cardiovascular disease in chronic kidney disease, invasive versus non-invasive. This is a difficult topic. There's a lot to cover, and there's lots of different areas in cardiovascular disease. So I'm going to be focusing on a few areas in particular. These are my disclosures for those of you who are interested. So the learning objectives for today's talk are to review challenges and clinical data of cardiovascular disease management in patients with chronic kidney disease that need PCI, to discuss shortfalls in current cardiovascular disease studies in patients with chronic kidney disease, and to discuss some approaches to minimizing contrast exposure during intervention with new devices and low contrast and imaging guided procedures. So let's start off with why this is important. Cardiovascular disease accounts for 53% of all deaths with a known cause in patients with chronic kidney disease. It remains the leading cause of death after renal transplantation, which is obviously a major societal impact. The causes of disease can be really broken down biologically into atherosclerosis, primary muscle problems such as cardiomyopathy, pulmonary hypertension, arrhythmia, often related to electrolyte imbalance, abnormal vascular remodeling that impacts the entire vasculature from things like hypertension, and valvular disease. To make this more focused, today we'll be focusing on coronary artery disease and valvular disease, and we won't really be touching on these other areas which other investigators and other participants of this program will take on specifically. So let's start about risk. So why do we specifically talk about patients with chronic kidney disease? Well, as I mentioned, the leading cause of death of patients with chronic kidney disease is cardiovascular. It accounts for 53% of all deaths with a known cause. I already mentioned to you that it's the leading cause of death after renal transplantation, but this last point is particularly problematic. And that is that exclusion from randomized controlled trials has led to an extreme paucity of data, making cardiovascular management in this population very challenging. That means we're kind of going less on evidence and more on experience. And while there are some advantages to that, there are certainly disadvantages. I'd like to start off by mentioning that generically lumping patients into the term chronic kidney disease is probably not fair. Not all chronic kidney disease is equal. In this study of 15,000 patients with a mean follow-up time of 6.2 years, you can see that the classic description of chronic kidney disease, which is a GFR of less than 90, is actually very different depending upon what your GFR cut point is with regards to your risk of atherosclerotic cardiovascular disease. Thus, the level of GFR is an independent risk factor for atherosclerotic cardiovascular disease and de novo atherosclerosis. And you'll see in this study that really a cut point of about 60 has a significantly increased hazard compared to those patients who are higher. Why does that matter? It matters because we need to think about these things in a systematic way. And if you look at this study, those patients with chronic kidney disease are very different to those patients who actually have end-stage renal disease and are on dialysis. This is a study of 230,000 dialysis subjects, and we already know that dialysis portends a poor prognosis. But when you put it in this type of perspective, that a 25-year-old with end-stage renal disease on dialysis has the same annual mortality as an 80 or 75-year-old in the general population, it puts into perspective some of the challenges but also some of the opportunities to study hard endpoints in this patient population. Let's start with atherosclerosis. Here's the problem. Here's a patient in December of 2017 with diabetes, hypertension, hyperlipidemia, and chronic kidney disease stage 5. You can see that the artery is severely diseased. The patient elects to undergo medical management as, believe it or not, the patient was relatively asymptomatic. But look what happens in the span of only a short time. Severe progression of atherosclerosis in the proximal right coronary artery, severe progression in the mid-right coronary artery, further ischemia, and a very late presentation with symptoms in patients with CKD. What if we look at the guidelines? Maybe we can look at the guidelines and get some help. Well, the KDOQI recommends frequent evaluation for CAD, including with angiography in high-risk dialysis patients. This is, of course, based on non-randomized data, but on data like we just saw, and that is that when you go on dialysis, there is something about that metabolic milieu which makes you progress and have coronary disease. There's insufficient consideration for procedural risks, and really all the data we have to date is, in fact, outdated. Save the ischemia CKD trial, which I'll speak to you about briefly. The KDIGO recommends aggressive approach of prevention of contrast nephropathy at relatively high EGFR, and the recommendations are limited and therefore relatively non-controversial. Easy to be non-controversial if you're not that committal. In 2018, the KDIGO did write a position paper which highlighted the lack of quality evidence, which we already mentioned, and also to bring to the attention possibly the radial artery approach and the advantages and disadvantages in patients with chronic kidney disease and end-stage kidney disease. Unfortunately, the cardiovascular disease guidelines are not that much more helpful. In 2012, the AHA recommended that we be careful about prophylactic strategies for contrast-associated acute kidney injury, and they also recognized the lack of data in chronic kidney disease. In 2018, the ESC recommended hydration and statins and hemofiltration in patients to prevent chronic contrast-associated acute kidney injury was likely not justified. So we're not getting very far here. There is, in fact, minimal societal guidance. We clearly need for updated guidelines vis-a-vis the CKD, end-stage kidney disease, and catheterization. We need incorporation of the ischemia findings and other contemporary trials, of which there really aren't many. We need to understand the radial and brachial cath access sites and whether that further jeopardizes potentially patients requiring AV fistula. And we haven't really incorporated the findings of the PRESERVE study, which essentially showed that normal saline was essentially as effective as other agents such as sodium bicarbonate. When should we do coronary intervention? These are basically consensus opinions for left main disease. That makes sense because it's the same thing in the general population. If you have left main disease, you have a poor prognosis, whether or not you have chronic kidney disease, and there's a survival benefit even in the non-CKD population, triple vessel disease, and severe angina, which speaks for itself. The utilization of early intervention in acute coronary syndrome should not differ by CKD status. I'm going to talk to you about this concept of renalism later on. Prehydration is probably good, but there's probably certain situations where it's bad. And consider dialysis access prior to selection of your cath site. So, be careful if you're going to use someone's brachial artery and not their radial artery. Very little data on CKD specific guidelines, and there are some other resources. But in general, I have to say, neither the nephrology guidelines or the cardiology guidelines are helpful in CKD patient populations. What about the indications for coronary angiography in general? Well, we know that patients who are asymptomatic should probably not undergo diagnostic testing for CAD, although there is a comment about patients with high risk of diabetes being assessed. I would probably say that should probably be chronic kidney disease as well, but it isn't specifically mentioned, again, due to this very, very small amount of data. There's no data to suggest that indications for coronary angiography should be different in CKD. All right, so show me the data. Not much historically, so we don't know a lot about this. So let's talk about the ischemia CKD study, which is probably the most important study that we're going to talk about. The ischemia CKD study was a randomized controlled trial taking patients with an eGFR of less than 30 or on dialysis and randomizing these patients to 1-to-1 an invasive strategy with optimal medical therapy plus a cath and optimal revascularization if suitable, or conservative therapy, which basically is a strategy trial. Either you do invasive strategy up front or you do a conservative strategy up front and wait until the patients become symptomatic if they do, and then follow them up in this study at a median of 2.3 years for a composite of death or myocardial infarction. A very well-intentioned study, and to be honest, probably the most important data that we were going to see in some time. As I mentioned, you basically have to have either end-stage renal disease, 51% were on dialysis, or an eGFR of less than 30, and at least moderate ischemia on an exercise or pharmacological stress test. Please take note that this is a site-determined stress test, which was different to the main ischemia study. If you had a low EF, NYHA class 3 or 4, too much angina, or an acute coronary syndrome, or stents or bypass within the 12 months, you got excluded. This is a quick comparison of the ischemia study versus the ischemia CKD study. And the main differences are, these are the patients who have kidney disease. They did not get a preemptive CT scan, possibly due to the increase in contrast required, but also the endpoint in ischemia CKD was a hard endpoint of death of myocardial or myocardial infarction. Importantly, there was no core lab review of stress test. Keep that in mind, it's going to become important later on. How did you determine ischemia? Well, they either had a SPECT or a PET, an echocardiogram, an MRI, or an exercise treadmill stress test. The primary endpoint was time to death or myocardial infarction, and major secondary endpoints included the above, but also hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. Quality of life was a separate study. So let's look at the endpoints. In the conservative arm, at a mean follow-up of 2.3 years, the death or MI occurred in 36.7% of the conservative group and 36.4% of the invasive group. So no different with the conservative strategy versus an early invasive strategy. Non-significant as expected. In a Bayesian analysis, pointing towards that one might be better than the other, again, there was no difference between these different groups. What about the major secondary endpoint when included death, MI, hospitalization for unstable angina, or heart failure, or resuscitated cardiac arrest? 39.7 in the conservative group, 38.5 in the invasive group. So looks like at the moment, conservative and invasive, pretty much the same. Same non-significant hazard value, non-significant by a Bayesian analysis. Other secondary endpoints, death alone, not different. Cardiovascular death, not different. Myocardial infarction, not different. Procedural myocardial infarction, not different, although it's difficult to understand this because the conservative group could only get a procedural MI if they ended up later on switching over to the procedure arm. And spontaneous MI was a little interesting because now we're starting to approach some significance, and I think we should take that into account, but again, not significant. Unstable angina, again, approaching significant with a benefit for the invasive arm, and heart failure, which ended up also being non-significant. Interestingly, stroke was considerably higher in the invasive group arm. Also, interestingly, the stroke risk continues to go up over time. So this is a little bit difficult to understand. One could consider an increase in stroke at the time of instrumentation, but the fact that the curves continue to separate suggests possibly something to do with dual antiplatelet therapy, but you would expect the invasive group to be on dual antiplatelet therapy longer. So a difficult finding to explain. Procedural was higher in the invasive arm. Now, what about the different subgroups when we analyze? No difference in diabetes, no difference in new or frequent angina, in optimal medical therapy, no difference in dialysis patients, but it turned out that severe ischemia started to look like it may favor more invasive therapy. Of course, the probably missing link here is the amount of coronary artery disease, which is still under investigation. If you look at the same endpoints for the secondary outcome, it's essentially the same pattern. So the authors concluded that an initial invasive strategy did not demonstrate a reduced risk of clinical outcomes as compared with an initial conservative strategy. Let's take a deeper dive into this. So when we look at the statistical analysis, the original planned sample size of approximately 1,000 patients was revised, and that was because of slow recruitment. So they're starting off with 1,000, now they're down to 650. They performed the calculations in 2015 and determined that an enrollment of 500 patients at a follow-up of 3 years would provide 81% power for a primary outcome reduction of 23 to 27%. But look at this cumulative 4-year event rate in the conservative strategy group. They're estimating 60 to 75% of all the patients would either be dead or have a heart attack within 4 years. That's exceptionally high. Nonetheless, the authors re-estimated the power calculation, and I should say the authors, I was one of these authors, and then came up with the blinded data of a final sample size of 777, more than 80% power to detect a 22 to 24% reduction, with an event rate of 41 to 48%, which is not unreasonable, especially when it's based on blinded data. So they were thinking about getting 240 to 270 primary outcome events. Now, let's take a look at those patients who actually had an angiogram. So despite 388 patients being randomized to the coronary angiography arm, only 85% actually got an angiogram. And the main reason they didn't get CAFed was some patient preference and intercurrent illness. So they're either too sick or the operator or the doctor thought, I don't really want to cause any harm to them. Let's give it a skip. All right. Now, what about patients who actually got revascularized? Well, this is a little bit of a shocking slide. So from all the patients who were randomized to an initial invasive strategy, only 50% of them actually got revascularized, 85% by PCI and 50% by CABG. And why is it that only 50%, even though they all had moderate to severe ischemia on stress test, ended up getting revascularized? Well, if we look over here at the reasons, 75% of patients, despite having moderate to severe ischemia on their stress test, actually had no obstructive disease. So these are essentially patients who have healthy coronary arteries. They don't have coronary artery disease. But that's very important because this is an intention to treat analysis. So essentially, all these patients get lumped into the same group. Now, these patients obviously are lower risk. So what does revascularization not do? We know that it doesn't reduce death in any study to date, right? Stents or revascularization in the chronic coronary syndrome patient population have never been shown to reduce death, and they don't reduce cardiovascular death. Has any medical therapy versus revascularization study in stable CAD shown a reduction in death? The answer is no. What can revascularization do? Well, we think if you basically plug up someone's artery that's very tight and they're at risk for rupture, you can reduce their spontaneous myocardial infarction. That's probably true. So there's a trend towards that. You could probably reduce them from having plaque progression and reduce their risk of getting unstable angina. That's almost kind of trending true. These two were not pooled. And if we go ahead and look at the statistical power then, 388 patients were the invasive arm. 85% underwent invasive angiography. So now we're down to 326 patients. Only 50% of patients underwent revascularization. So half the power to detect a difference is lost. And where is the as treated patient population from ischemia CKD? You obviously can't prevent unstable angina or heart attack with revascularization if you don't get revascularized. So there's also bias in this analysis. The selection of PCI versus CABG or medical therapy in cases in which revascularization would not be appropriate was left to the discretion of the treating team. That means if the operator thought, I don't really want to harm this person, I'm not going to enroll them and I'm not going to put in stents. And this is the concept that I mentioned to you before of renalism. Here's a study which looks at patients who have a clear indication for revascularization, i.e. a heart attack. It doesn't get more clear than that. Big numbers, but you'll see that the incidence of revascularization in the CKD patient population is considerably lower than those patients without CKD. And this concept of renalism even happens in the contemporary age. If you look at revascularization in the ischemia trial without CKD, the ratio of revascularization to catheterization is about 83%, but the ratio of revascularization to catheterization in the CKD arm is about 60%. So why would that be? Well, the reason is this, that operators don't want to create harm. And they certainly don't want to create harm in their own arms. And what you'll notice is in those patients who have advanced CKD, the incidence of dialysis as a result of the procedure, presumably because it's randomized to procedure versus not, is more than threefold higher. So this threefold hazard of creating an increase of dialysis early on really creates an atmosphere where the operators don't want to intervene on patients even when they have a clinical indication. And here's the data to support that. If you've got chronic kidney disease and you create a contrast-induced nephropathy, about 1 in 4 people is dead at 1 year. And even if you don't have CKD and get contrast nephropathy, you have a very high hazard ratio, and 8% are dead at 1 year. And so we are left with this patient population with a very low GFR where there's no benefit detected. But again, it's because of a lack of data and power in order to be able to detect a difference. Are you confused yet? Well, I am. Let's take a look at some of the data that's out there before. Here's revascularization versus medical management of coronary artery disease in pre-transplant patients, a meta-analysis. So lots of articles studied. They break it all down. It ends up looking at 6 articles. So if you look at these 6 articles, what ends up happening is the trend starts to say it favors revascularization in pre-transplant patients, as you can see down here, although it doesn't completely meet statistical significance, right? With an odds ratio of 0.415. But look at the number of events and look at the different pattern. Some studies are wildly positive, some studies are negative. And the total number of events in this patient population is very, very small. There's many studies with no events in the revascularization group because there's only 19 patients. So even this meta-analysis is underpowered. And there's a selection bias in these registries because, of course, a lot of centers don't even list patients who have a lot of coronary artery disease. They just say, it's too high risk, we're not going to do it. And so what ends up happening is you get a cherry-picked group of relatively lower risk patient populations, and even then there's a trend towards better, improved revascularization. We haven't even touched upon the topic of how do you tell a surgeon to operate on a patient with known multivessel CAD. If you find one, let me know who they are. What about if we look overall at bypass versus stenting? So if we look at coronary artery bypass grafting versus PCI in this meta-analysis, what we see is that mortality is not different in the preserved group or the stage 3 or 3B to 5 group, but the MI rate is much lower in the CABG group compared to the stenting group, as is the repeat revascularization. But if you dive into the details, let's go ahead and look at the number of patients who have stage 4 and 5 CKD. It's actually only present on a single value. And so what you can end up seeing in this situation is that this is a very misleading study because actually this is a study of stage 3 CKD. Probably the most important and relevant data comes recently from our group at the Cardiovascular Research Foundation, where we looked at left main revascularization with PCI or CABG in patients with chronic kidney disease in the EXCEL trial. So what did we learn? We learned that those patients who had no CKD, either with PCI or CABG, did better than those patients with CKD, and that there was no difference in death, myocardial infarction, or stroke comparing PCI or CABG in the CKD population. But if we take a look overall at the risk, what we'll notice is that depending upon your eGFR, that risk changes. So the lower your eGFR, the lower your risk from having bypass surgery compared to having PCI. But that lower risk of all-cause death, myocardial infarction, or stroke at 3 years is counterbalanced by a significant hazard of an increased risk of dialysis. So you'll notice that the risk of dialysis is almost 5-fold higher in patients who had CABG, and the risk of acute renal failure was 3-fold higher. So how do you tell your patient that they may have a higher risk of dying if they have of stenting versus CABG, but they may end up with a 5-fold higher risk of going on dialysis immediately after procedure? So all of these things taken together really help us understand that we need a tailored individual patient approach. This is revascularization in patients with multivessel coronary artery disease and chronic kidney disease. No difference in death, stenting versus bypass surgery. But when we start to break this down in CKD patient population, what we start to see is that in patients who have a low eGFR, less than 45, that actually there's a protective effect of stenting because the CABG is more likely to cause you to go onto dialysis and create renal injury. But in those patients who have an eGFR of 45 to 60, actually there's no difference. As we come down in the group, we look at myocardial infarction. There's no significant interaction, and there's no significant difference in eGFR of less than 45, but there's a significant risk for PCI if you have eGFR of 40 to 45 to 60. No significant difference in eGFR of less than 45 for stroke, but 45 to 60, again, a benefit for bypass surgery. A benefit for stenting compared to bypass surgery. And obviously, repeat revascularization is always seen to be higher in patients who undergo stenting. If you look at the dialysis population, it's a lot different. That's why we can't lump these together. You'll see that the risk is much higher in patients who undergo stenting for both death, myocardial infarction, stroke, as well as repeat revascularization. So that's how I'm going to end on the session of coronary artery disease and provide a mini summary, and that is, I'm really none the wiser. The data that's available today is confusing, it's underpowered, it's poorly collected, and we have a tremendous paucity of data where we're left again to move forward on experience or trials that really haven't presented us all of the information that we need to make decisions. While I understand the value of an intention to treat analysis, we also have to think about what happens to patients who are actually treated the way we wanted them. What happens to patients who get revascularization versus those who do not? So for the last sort of 10 minutes or so, I'm going to move on to aortic valve disease and CKD. The first thing you'll notice is that compared to patients who have a higher eGFR, the incidence of moderate to severe aortic stenosis goes up rapidly compared to patients with better GFRs. And the same thing happens also with regards to aortic regurgitation, probably because of volume overload, but not really a significant difference in severe aortic regurgitation. How much CKD is there in patients undergoing transcutaneous aortic valve replacement? Well, it's pretty small at the CKD5 level. So again, we're going to have a paucity of data, but a reasonable number in CKD4. And so if we look at the TVT registry of patients undergoing TAVR, the good news is there appears to be a temporal trend that's improving. So those patients with end-stage renal disease start to look like they're having lower in-hospital mortality, and those patients with CKD start to approach the mortality of patients who have no CKD. Not all CKD is the same, as I mentioned before. For patients undergoing TAVR, those patients who have moderate chronic kidney disease tend to do as well as the none or mild, but patients with severe GFR have a higher risk of death. And the exact cause of that death remains to be multifactorial, as we discussed earlier on. Of course, GFR was an independent predictor of risk. What happens in terms of outcomes? If we look at these 30-day outcomes, look at the risk in the CKD5 population. This is an enormous hazard. 38% a composite of death and new renal replacement therapy. 35% of patients at 30 days ended up on dialysis with new renal replacement therapy if they have CKD stage 5. Even 16% of those patients with CKD4. And that's probably a combination of hemodynamic insult as well as contrast requirements. We also can see that the 1-year outcomes are even worse, with 67% of patients with a composite of death and new renal replacement therapy, and 60% of patients developing new renal replacement therapy. What about aortic valve disease in end-stage renal disease? That's a different patient population. I'm purposefully separating them. The number of patients with end-stage renal disease is increasing dramatically, but unfortunately, the probability of survival remains low. The long-term outcomes in these patients is still poor. A TAVR and dialysis patients, if we go ahead and look at this, what you'll notice is that the overall STS predicted mortality is much higher in dialysis patients compared to the non-dialysis patients. Of course, that's not necessarily unexpected. If we look at the 1-year patient mortality, the patients who are on dialysis have a significantly worse outcome than compared to those patients without dialysis. And you can see a creatinine less than 2 without dialysis has a magnitude lower risk of death compared to patients with a creatinine greater than 2 without dialysis, i.e. CKD, and those patients who are on dialysis. The good news is that in patients with end-stage renal disease, the mortalities are going down, so we are getting better, and so there is hope for this patient population. What's the mode of morbidity and mortality? You know, patients with older age, pre-existing chronic kidney disease, they have heart failure, they have complications because of severe calcification, they end up postoperatively with a lot of nephrotoxins and decreased heart function. So these are very, very sick patients. If we look at TAVR and acute kidney injury in the national inpatient sample, you can see this very high hazard ratio of patients who have CKD to develop a chronic acute kidney injury, almost a threefold risk, and almost a fourfold risk of acute kidney injury requiring dialysis. In this CKD bleeding analysis, CKD patients are a very unique patient population in the fact that they have both an increased ischemic risk, an increased risk of valvular disease, but also have an increased risk of bleeding, probably due to a combination of platelet dysfunction and also due to vascular access complications. You can see that your eGFR less than 30, the risk is significantly higher of a bleeding complication. And that increase in bleeding complication leads to an increase in transfusions, and many studies over the years have shown an increased risk of mortality in patients who have increased risk of transfusions. Again, if we look at this data of patients in the partner registry, you'll see that the risk is very high at both 30 days and 1 year. Finishing off with mitral valve disease quickly, what is the impact of CKD on the MitraClip patient population? You can see that those patients who have low eGFR, again, the same common pattern in both univariate and multivariable analysis, the lower your GFR, the higher your risk of mortality. Exactly what the cause of that mortality is remains unclear, but you do die more often. In the European GRASP registry, those patients who had freedom from mitral surgery or actually a continued MR, it was much lower in the CKD population than not. What are the predictors of attenuated outcome? Calcified leaflets, as you can expect, a presence of mitral annular calcification, multiple clips, all increased your risk of hazard of failing your MitraClip procedure. The multivariable predictors of death in MitraClip, not surprisingly, an increased risk in patients with creatinine of greater than 1.5. You'll notice that the risk of having a high creatinine or having kidney disease is actually even higher than having a poor EF. So MitraClip can improve eGFR results and improve survival. So that's also a very good thing. So one thing that you can do in patients where is you can rescue some renal function, and that clearly improves their outcome over time. So quite purposefully, I've left my introduction slide and my conclusion slide the same. And that is because this is a very complex population with a paucity of data. And I hoped you learned something over the last 30 minutes or so. But perhaps the takeaway message is we really need to invest into well-conducted, well-powered randomized controlled trials, but also to understand the mechanism of death in these patients, which remains to be very unclear. For the time being, for coronary artery disease, those patients who have reduced ventricular function, those patients who are symptomatic, and those patients who are at high risk of sudden cardiac death may be the ones who benefit the most from revascularization. But I would not take at the moment the ischemia CKD patient randomized controlled trial as the definitive trial because of the things that I mentioned earlier. And for valve disease, we again see that the CKD5 patient population is a particularly high-risk patient population, but that things are getting better as we learn more and we get better and improve on the learning curve. I'd like to thank you all for your time. I hope this was educational and useful, and I'll see you next time.